So I'm going to present actually a very dramatic case of a PE, so get ready here. This is a 39-year-old Amish woman. I come from Ohio, and we have a good Amish community there. She came with a large orbital rim meningioma, admitted following elective bifrontal craniotomy for tumor resection on November 2nd. And we just need to keep track of the timeline. November 2nd, 2018, she had her surgery, past medical history of infrapopliteal DVT, treated in 2017 with 3 months of Xarelto, and she's been maintained on some kind of homeopathic anticoagulant. She's got a family history of DVT. She's never a smoker, occasional alcohol. On post-op day 5, patient had the new onset tachycardia and increased oxygen requirements, which is new. Subsequently, she got a CT angiogram, which showed heavy thrombus burden in bilateral pulmonary arteries and a saddle PE that we saw briefly. Importantly, also her RV to LV ratio was pretty dilated. RV is pretty dilated. And on physical exam, so before we get into the vitals, this lady is morbidly obese. She's actually pretty big. Her heart rate is 120 to 140. She's hypotensive, 76 over 42. Breathing 30 times a minute. She's 82% on room air. Initially, she's tachypnic and distressed. She was initiated on phenylephrine drip and electively intubated. Her PESI score was 159, which is very high risk, and the simplified PESI is also 8.9, which is also high risk. Her transthoracic echocardiogram here, we can see severely dilated RV, reduced function. Even the left ventricle is pretty much compressed from with septal flattening and systole, suggestive of RV pressure overload. So the patient was taken emergency to the cath lab. Upon arrival, her blood pressure kept even dropping. She became bradycardic. She was started on epi, atropine, without any further improvement. Subsequently, she had a PA arrest, CPR, multiple rounds of epinephrine, VT, cardioverted. We eventually maintained ROSC at 10 minutes of ACLS, and then she again goes into PA after approximately 2 minutes. So the decision was made to proceed with emergent VA ECMO, stabilized after the VA ECMO, and then we made a decision to proceed with a thrombectomy. So here the device of choice was the Inari device. So we went up with a pigtail, take angiogram of the right pulmonary artery, we see thrombus. We did a couple passes of Inari thrombectomy, embolectomy device runs, and then with subsequent angiogram, we see better perfusion to the lung. On the left side, similar story. We went up with a pigtail, angiogram, Inari, embolectomy, and then after that, we see also some improved perfusion. So we're able to get significant amount of thrombus, and that's the picture. And I may be imagining things, but these to me, they pretty much correlate with the thrombus that I just see in the CAT scan. Following the timeline, her RV, this is an echo done on the 14th of November. We see the RV has completely normalized in terms of size and function. And this is pretty much the timeline of her course in the hospital. On the November 2nd, she had the surgery, PA arrest. On the 7th, on the 12th, the ECMO was decannulated. She had hit, confirmed by PF4, which switched her to bivalve, and eventually Coumadin. She got extubated, transferred to the floor, and then discharged home, and we did see her in clinic subsequently. So the lesson learned in the patient with this acute PE and hemodynamic embarrassment, rapid thrombus debulking is necessary. The choice of catheter-directed therapy is important, and this patient fit what we thought is she's a good candidate for the Inari device. VA ECMO can be utilized as a temporizing support to allow time to perform the urgent thrombectomy. And despite the hemodynamic support, we thought thrombectomy should still be performed to allow recovery of the RV in a timely fashion so as to wean the VA ECMO earlier.
Perfect.
Thank you.
Thank you for a great case. PE cases are always challenging, especially when they present that sick. So I have a couple of questions for you. Was that enough? Like, do you measure pre and post embolectomy pressures to see how much pressures went down? And was there consideration for post removing that clot from the main PA and the big left and right PAs to give like catheter-directed thrombolysis to even, kind of give more?
So all of these ideas, they really actually came into our mind. The pressure didn't markedly drop after the embolectomy. There was heavy thrombus burden, even in the distal, smaller arteries. But particularly for this patient, she just had a craniotomy, and the neurosurgeons were really concerned about thrombolytic therapy at this point. They were okay with VA ECMO and heparin, but beyond that, they were still
Yeah, good point.
anxious.
Yeah.
How did the diagnosis of HIT factor into your treatment options?
So we noted that her platelets have been trending down, and a lot of things can cause this, with the thrombosis, the VA ECMO sometimes. And then we sent the panel, and that she wasn't too, we defined HIT, and that's when we switched her to bivalve from heparin.
Did you find any, the cancer probably was the underlying hypercoagulable state in her?
So it was a benign meningioma, but I think that's probably also increases, predisposes her to more, to be more prothrombotic. But again, this lady has a history of DVT 3 years ago, and she's got a family history of DVT. We
she's
screened,
lifelong.
yeah, we screened, like we sent the most common prothrombotic. We couldn't really find anything.
But even if sometimes these people need to be on
Lifelong.
lifelong anticoagulation. Go ahead, sir.
Excellent case, Most Security from Arizona. I just want to make a comment. There are several cases now that shows tremendous improvement, but almost uniformly, that has been in the setting of using the ECMO. So in other words, if you just do the catheter-based intervention without the
The
ECMO
ECMO.
support, the data has been dismal. So that 24 hours of protecting the heart and the lungs with the ECMO is very essential.
Good point. Thank you for making that point. Please feel free to
Mazen.
come up to the microphones and discuss.
Yeah, Mazen, I want to first of all say that I think the key points of this patient is the substrate for a massive amount of thrombus, right? She's morbidly obese, she's postoperative, she's got a tumor, and so she has a history of prior DVT, so it's not surprising that this woman would not only have a postoperative pulmonary embolus, but she would propagate a huge amount of clot. And I think what's stark about this patient is how quickly patients like this can die, and the rapid hemodynamic deterioration that occurred is what I think is the key issue here, and I applaud you for immediately going to the big gun and stabilizing this patient with ECMO, which allows you to then buy time and make a decision as to what you're going to do next. So I think this was handled beautifully.